My name is Daniel Vaina. I'm a medical oncologist, director of the GU and phase 1 programs at the West Kansas Center Research Institute in Memphis, Tennessee. And I wanted to thank the organizers of the Oncology Clinical Pathways Congress for inviting me to give this lecture on the benefits of clinical pathways in the systemic treatment of bladder cancer. Here are my disclosures. So the learning objectives for today are going to be to summarize the concept of maintenance therapy with immunotherapies in metastatic urothelial carcinoma, to evaluate the sequential immunotherapy versus standard of care approaches in first-line metastatic urothelial carcinoma treatment, and to integrate the clinical safety, efficacy, and cost-effectiveness data of approved and emerging first-line, second-line, and subsequent line therapies in metastatic urothelial carcinoma clinical pathways. We have a lot to talk about, since there's been a lot of new drug development and new drugs approved in urothelial carcinoma in the last few years, and it's become a very complex field in terms of the therapeutic spaces and how to choose among the different therapies that are available. And so there's been a lot of challenges in the last few years in deciding what's best for each patient, and we're going to hopefully cover all that today. We're going to talk about the epidemiology and the stage presentations of urothelial carcinoma. And there's approximately 81,000 new cases of bladder cancer and approximately 17,000 deaths from bladder cancer in 2020. And that doesn't include malignancies of the upper tract, including renal, pelvis, and ureter, which can also lead to a significant morbidity and mortality. And these numbers are in the United States. And approximately 70% of new bladder cancer cases are described as non-muscle invasive as presentation. There's several different categories of non-muscle invasive urothelial carcinomas in terms of distinction of grade, low versus grade, affecting the biology of the cancer, and distinctions in the stage, going from a non-invasive TA tumor to an invasive into the lamina-appropriate tumor, described as T1, or carcinoma in situ. So non-muscle invasive bladder cancer is a very heterogeneous group of cancers in terms of the natural history and the aggressiveness in the natural biology. And the remainder of cases of new bladder cancers are diagnosed with more invasive disease. We know that the risk of distant metastatic disease significantly increases over time, especially as the cancer progresses into muscle invasive disease. And that's when more aggressive local treatments such as radical cystectomy or chemoradiation come into play in order to increase the cure rates and prevent and decrease the chances of distant metastatic disease that are ultimately fatal. And then we have a small proportion of patients that present already with locally advanced or distant metastatic disease that is generally considered incurable. So the natural history of urothelial carcinoma is sometimes very long and complex, and this has resulted in many different therapeutic spaces for urothelial carcinoma. And as drug development moves forward, there's been an evolution of many more therapeutic spaces over time as we have distinctions between pre and post this and that therapy. So typically there's three major large therapeutic spaces in urothelial carcinoma for drug development. The first being the non-muscle invasive category of patients that typically present to the urologist and undergo initial urological treatment and are stratified based on risk. And there's varied stratification models that we're not going to discuss today, but mostly take into account number of lesions, size of lesions, and aggressiveness of the lesions. And often adjuvant intravesical therapy such as BCG is considered for patients at higher risk after TURBT. The next therapeutic space then in that subgroup would be the patients who are BCG failures and BCG unresponsive. And those patients are offered a variety of different treatments, typically including radical cystectomy as the standard, but now recently with the evolution of several different treatments in development and also approved, such as pembrolizumab, other intravesical chemotherapy options, and many, many trials in progress. And there's a lot of heterogeneity depending on the types of lesions that are non-muscle invasive in a specific patient and the appropriateness of each treatment or another. The next big category are the muscle invasive bladder cancers, described as T2 or higher cases, where typically the Standard treatment considerations include neoadjuvant chemotherapy if the patient is cisplatin eligible. The chemotherapy is often considered our MVAC or GC, to be followed by radical cystectomy. There's still controversy regarding the role of adjuvant chemotherapy in many patients without good clinical trial data to support the role of adjuvant chemotherapy as opposed to neoadjuvant chemotherapy. And there's also many trials in progress as relates to immunotherapy, although some of the trials have already resulted with negative results as relates to immunotherapy. We're not going to discuss this further today, as this is outside the scope of this presentation today for metastatic disease. In the muscle-invasive therapeutic space, there's also the role for chemoradiation for selected cases. These cases often require complete TURBTs and follow-up TURBTs over time, follow-up cystoscopies. And there's many trials in progress in that subset as well that often relate to the role of immunotherapy with chemoradiation or after chemoradiation. And we're also not going to discuss that today. In terms of metastatic disease or metastatic disease that is recurrent after local therapy, that is where the role of systemic therapy plays a bigger role, plays the main role. And there's many therapeutic spaces with first line space, second line space, and then right now with so many treatments being available, third and fourth line space being also new developments in the last few years. Historically, first line therapy for metastatic urothelial carcinoma has been divided into patients who are cisplatin eligible and cisplatin ineligible. The typical criteria that are used for cisplatin eligibility revolve mostly around renal function, but some other criteria as well, including performance status and neuropathy as an example. And they're summarized in general as a Galsky criteria. For patients who are cisplatin eligible, the current standard that's commonly used is chemotherapy with cisplatin gemcitabine. In the second line setting, those are patients that typically are progressing after first line chemotherapy, or patients who are recurring with metastatic disease within 12 months after prior neoadjuvant chemotherapy or adjuvant chemotherapy. And then third and fourth line spaces are patients who progress after second line options. A lot has changed in metastatic urothelial carcinoma over time, as we have discussed. Prior to 2016, there were very few options available other than chemotherapy, which was restricted essentially to first line chemotherapy, which was cisplatin based for many, many years, and second line cytotoxic chemotherapy options, typically taxanes, were considered in that space. In 2016, we started to see the emergence of immunotherapy with anti-PD-1 and anti-PD-L1 agents, and many agents were approved in that time period based on phase 2 data with response rates and based on accelerated approvals. And there were many, many different immunotherapies approved and used during those years. And since 2019, we had the appearance of 2 additional agents with different mechanisms of action, including an agent that inhibits FGFR, and the emergence of an antibody drug conjugate against nectin. And we'll discuss more in the talk. Discuss this more in the talk today. And the current trends of the field and the current trials that are being performed are heavily exploring the sequencing of chemotherapy and immunotherapy across the spectrum of metastatic urothelial carcinoma, and how to integrate all these different treatments into the best treatment for our patients. Second line immunotherapy, as I said, is a result of the performance of several phase 2 trials and the results of a large phase 3 trial, Keynote 45, with several single-arm studies that showed significant response rates in the 20 to 30% range with anti-PD-1, anti-PD-L1 agents for metastatic urothelial carcinoma, and resulted in approvals irrespective of PD-L1 status. And the phase 3 trial with Keynote 45 was the trial that showed the survival benefit for pembrolizumab compared to standard chemotherapy in that space, and is used by many physicians in that setting. The next evolution of um, uh, management in this disease was the understanding of the FGFR landscape and how FGFR mutations and fusions can be relevant in different cancers. We know that FGFR abnormalities are present in many different cancers, with urothelial being among one of the top tumors in terms of showing abnormalities. And especially in upper tract urothelial these mutations can be even more prevalent. The FGFR field is very complex, with different tumors showing a predominance of different types of receptors being more altered. In urothelial carcinoma, for instance, there seems to be a predominance of FGFR3 abnormalities, as opposed to some other tumors where there's a predominance of FGFR2. The other difference has been in terms of the abnormalities being characterized as mutations or fusions in different tumors, and there are different patterns of activity and response rates depending if the abnormalities are mutations or fusions. And in addition to that, there's many different types of mutations and many different types of fusions that are present in those tumors. So it's a very complex field as a whole. In urothelial carcinoma, erdafitinib has been tested and FDA approved as the first FGFR inhibitor that's available in the clinic. The BLC 2001 trial was a single-arm phase 2 trial that was performed in patients who had metastatic urothelial carcinoma progressing after prior chemotherapy. Patients needed to have either an FGFR3 mutation or an FGFR fusion on a companion diagnostic. And notably, 24% of those patients had had prior immunotherapy. And all the patients were required to have prior chemotherapy, but only 24% had prior immunotherapy. And the response rates were shown in the slide, are shown in the slide here, with the significant overall response rate based on blinded investigator assessment of 32% for patients, for all comers in the study. And as described in the bottom of the slide, there was a difference in response rates for patients who had mutations as opposed to fusions. There were many more patients in the study with mutations, for which the overall response rate was approximately 40%, versus patients with fusions, where the overall response rate was around 11%. The BLC 2001 study had several subset analyses that are shown here, where there was no major difference among the different subsets. In general, the interesting finding, though, that was exploratory related to the prior use of immunotherapy and the prior experience the patients had with prior immunotherapy prior to going to the study. As I mentioned, only a subset of patients in this study had prior immunotherapy, and of the patients who had prior immunotherapy, 13 of 22 patients had responses to erdafitinib. On the other hand, on an exploratory analysis of the 22 patients who had the prior immunotherapy, only 1 out of 22 patients had responded to the prior immunotherapy prior to study entry. This is of unclear significance in terms of clinical practice, as this was an exploratory endpoint that is analyzed in a retrospective fashion in this study, but is an interesting thought-provoking question in terms of a prospective evaluation in the future regarding, as we talk more about clinical pathways, if there is a role for better selecting patients who should receive next line of therapy with immunotherapy or with FGFR inhibition if they have FGFR mutations or fusions. And if there are different pathways or biological pathways that are directing that these tumors will or will not be responsive to immunotherapy if they have FGFR mutation. So there's a lot of work ongoing in many different cancer centers to further understand the biological implications of and the immune responsiveness of tumors that have FGFR abnormalities. From a duration of response standpoint, we can see below that the responses to erdafitinib are often durable, although we still don't have long-term data to know how durable they are going to be in terms of long-term control. The other available agent in the clinic today is enfortumab vedotin, which is an antibody drug conjugate targeting nectin, which is an extracellular molecule that basically is targeted by enfortumab vedotin, which binds nectin and conjugates MMAE to a linker and acts as a microtubular agent that leads to cytotoxicity. And EV201 was a trial that led to the approval of enfortumab vedotin. It included patients who had metastatic urothelial carcinoma that were progressing after prior immunotherapy as well as prior platinum-based chemotherapy. So typically those were, for the most part, third-line patients. And notably, the trial excluded patients with grade 2 neuropathy or uncontrolled diabetes, and there were specific criteria for that in the study, given the concerns that were previously known related to these types of antibody drug conjugates and the propensity for neuropathy as an example. So the results showed a 44% overall response rate with a complete response rate of 12% and a partial response rate of 32% and a median duration of response of 7.6 months. But take into account that these were advanced patients with third and fourth line setting. That these were very relevant data and the response rates that we really had never really seen in that therapeutic space. And that resulted in the approval of enfortumab vedotin. In terms of safety considerations, both of those agents can have several toxicities, and the prescriber needs to be very familiar with them. Erdafitinib is the FGFR inhibitor that can cause a large variety of toxicities in many different organ systems. The drug requires safety ophthalmologic evaluations with retinal exams for early detection of toxicity. There's concerns about GI toxicity. There's concerns about phosphorus levels. The FGFR inhibition leads to increases in phosphate levels due to decreased excretion of phosphorus at the level of the kidney. And not only this can lead to toxicity that has to be managed, but this can also be considered a therapeutic endpoint where the dose of the drug is adjusted based on the phosphorus level. But there's a sweet spot in terms of having a phosphorus level that is high enough to support that the drug has efficacy, but at the same time, a phosphorus level that's not too high to lead to toxicity. So it needs careful monitoring of phosphorus by providers. Enfortumab vedotin, on the other hand, as we discussed already, can have several toxicities that relate to this class of agents. And in particular, the things to pay attention to are hyperglycemia with some episodes of DKA seen in some patients on the study, with peripheral neuropathy that can worsen and needs to be monitored during the study. Ocular disorders that can occur with dry eyes and dryness of mucosa. Skin reactions in the form of a rash, which may require dose reductions and site sterilizations, and there's other toxicities not listed here. But it also requires investigators to be very familiar with the toxicity profile of enfortumab vedotin. And the most recent development in metastatic urothelial carcinoma occurred at ASCO this year with the presentation of the Javelin 100 phase 3 trial, which was a large trial that evaluated the role of switch maintenance avelumab in patients who had previously received first-line platinum-based chemotherapy. So patients were randomized into the study after having completed between 4 and 6 cycles of prior standard first-line chemotherapy. And only patients who had complete response, partial response, or stable disease after the prior chemotherapy were enrolled into the study. Patients were then randomized into avelumab, immunotherapy, or best supportive care with observation. And the primary endpoint was overall survival, with the primary analysis population being all randomized patients and also the PD-L1 positive population. The patients who enrolled in this study were typical patients that are treated with chemotherapy for metastatic urothelial carcinoma. 70% of patients had, approximately 70% of patients had cancers of the lower tract, including the bladder, and 30% upper tract. And about half of the patients had visceral disease. And approximately 50% of patients in the overall population was PD-L1 positive. In terms of prior chemotherapy regimens, approximately half of the patients had cisplatin gemcitabine, and the other half that had non-cisplatin regimens or a combination of cisplatin and carboplatin. And those numbers are pretty typical of what we see in the first-line setting for metastatic urothelial carcinoma. 72% of patients in the overall population had prior CR or PR with first-line chemotherapy, and 28% had stable disease upon entering and being randomized into the switch maintenance avelumab study. This study was positive for overall survival, with a median overall survival of 21 months for the avelumab arm, as opposed to 14 months for the arm that received observation alone. And there was also an overall survival benefit in the PD-L1 positive population. So this was the first study to show an overall survival benefit for the approach of combining a strategy of chemotherapy and immunotherapy in the first-line setting for metastatic urothelial carcinoma. Now, this is a very important slide in interpreting this study, and especially for purposes of creating a guideline or understanding the role of pathways, which is one of the key features of this talk. If we look at the number of patients who did not receive any further subsequent drug therapy, and you look at the subgroup of patients who stopped treatment because they had progressive disease, you see that in the group that had been randomized to observation alone or best supportive care, you can see that 24.7%, or 1/4 of the patients, received no second-line therapy or beyond after having received first-line chemotherapy. And along those same lines, we see that only 52% of patients who discontinued study therapy because of progressive disease, only 52% of the patients who had been randomized to best supportive care went on to receive a PD-L1 or a PD-1 inhibitor in the second-line setting, which would be one of the current standards of care. And if we look at the subgroup analysis, there was no major difference among the different subgroups in terms of the efficacy in this study. The response rates are difficult to interpret in a switch maintenance study because those are patients that already entered the study having had CR, PR, or stable disease at the time of entry into the study, and therefore this response rate is not representative of the activity of this regimen overall. It's only representative of the additional response rates they had when switch maintenance with avelumab was added. And what we see is an additional 9.7% response rate in the overall population, and a little bit higher, 13.8% in the PD-L1 positive population when avelumab was added after the completion of first-line chemotherapy. The progression-free survival was also significantly improved with the avelumab maintenance. And in terms of adverse events, there were no major surprises in terms of what is known about the toxicity of PD-L1 and PD-1 and PD-L1 immunotherapies in general in this population from what was previously known. So in terms of interpreting the study and for the purposes of developing guidelines and developing pathways, this study is somewhat difficult to interpret because it has to be interpreted in a historical context with what we would expect the survival to be if patients do not have switch maintenance. We know that historically, the patients who received first-line cisplatin gemcitabine from the prior phase 3 trials, they had a 7-month progression-free survival and a 15-month overall survival. And these trials were done, and the main phase 3 trial was done at a time where there was no significant second-line therapy available in terms of survival prolonging second-line therapy. So at that time, the expectation would be that patients would be progressing after approximately 7 months. And with carboplatin gemcitabine, historically in the first-line setting, the 6 months progression-free survival. If we then look at the approvals for the second-line immunotherapy trials, as an example, the second-line pembrolizumab trial approvals, the results of those trials showed 10-month overall survival for patients who received pembrolizumab in the second-line setting after previously progressing on first-line chemotherapy. So if you sum the first-line progression-free survival data of 7 months with cisplatin gemcitabine, and you say at that point is when patients would typically in clinical practice be switched to pembrolizumab as an example, and then if you take the second-line data, you'd say then they would survive 10 months from that point on. Then you'd sum up those numbers and you'd say you'd expect an approximately 17-month median overall survival for patients who were to receive cisplatin gemcitabine followed by pembrolizumab today as standard of care. On the other hand, you contrast this with Javelin 100 results where first-line patients who received cisplatin gemcitabine or carboplatin gemcitabine had a median overall survival of 21 months. And that also excludes the 3 months that they were receiving first-line chemotherapy as well. So you could argue that their overall survival, median overall survival, could be around 24 months. So on face value, looking at this, you'd say that switch maintenance truly appears to impact a true overall survival benefit, although we don't have trials that directly compare the immediate switch maintenance with subsequent treatment upon progression on second line. But the question, if Javelin 100 underperformed in the control arm, as I discussed, is a real question in the sense that only 50% of patients in the Javelin 100 who progressed in the best supportive care arm had subsequent CPI. And you could argue that that is not the standard, and you could argue that a large number of patients in clinic today, in practice today, in the United States would in fact be receiving second-line immunotherapy, arguing that perhaps the control arm of Javelin 100 could have been underperforming compared to standard approaches in clinic. The other fact that 25% of patients who progressed on the control arm never had any subsequent therapy is also surprising and suggests that the control arm on Javelin 100 could have underperformed. That being said, it's hard to know what that performance would have been. It's hard to know if the overall survival in the control arm had been greater. Would the study have had enough power to still be a positive study or not? Those are all speculations that we cannot solve at this point. We know that the safety was similar to what we expect anyway. And then the cost effectiveness of dual switch maintenance becomes very much unclear because we have a range of numbers in terms of really understanding what is the true survival impact of the switch maintenance approach versus the second line approach, as I discussed above, given all these questions about comparison with historical data. But a typical cost effectiveness discussion would include, for instance, what is the cost of avelumab over time for the presumed survival benefit that you're getting for our switch maintenance versus second line. And if you argued that the survival benefit is 3 or 4 months, you'd have to do the calculation of how much does it cost to give avelumab for this period of time that's resulting in an additional 3-month benefit, and do the calculation that way. So I think it's very difficult at this point to have a cost effectiveness analysis when we don't truly understand the magnitude of the survival benefit of this approach, although there's likely to be a survival benefit. And that likely survival benefit is very similar to other FDA-approved immunotherapy indications with similar survival benefits in that 3 to 4 month range. So definitely it is similar to other FDA approvals that we have today in other diseases. And in terms of patient selection considerations, the selection of patients should mostly be based on the response to prior chemotherapy, and in terms of making sure the patient doesn't have contraindications for immunotherapy. Investigational approaches that are being explored today are actively looking at the role of concurrent chemoimmunotherapy with several trials ongoing. We had InVigor 130, which currently has progression-free survival data which is promising, but there's immature overall survival data. We have 2 trials that were recently presented at ESMO exploring the role of immunotherapy combinations, and we had Keynote 361 looking at the role of concurrent chemoimmunotherapy. And we have a variety of trials looking at combinations of informal vedotin with other agents. And we have several novel targeted agents looking at different mutations and fusions and other FGFR inhibitors in development as well, and a lot of novel agents. So the field has been very prolific in drug development in metastatic urothelial carcinoma. So at ESMO this year, we had presentations on Keynote 361, which I'm not going to go through to the limited time, but the trial had negative results. And at this point, chemoimmunotherapy concurrently is not to be considered a standard of care in this disease. And we had the results of Danube also presented, exploring the role of combination of PD-1 and CTLA-4, and with negative results as well, so also not being the standard of care at this time. So how do I approach sequencing and the question about pathways in this disease at this time? I think the considerations a physician should have when seeing a patient in the first-line setting is, first of all, to determine the cisplatin eligibility using the Gaussian criteria. Often in practice, we deviate sometimes from the creatinine clearance cutoffs, and often consider split dose cisplatin as an example when patients have a creatinine clearance slightly below 60. So sometimes in clinical trials, there's more limitations to being able to do that than in real practice. But the considerations are first-line cytotoxic chemotherapy, and then based on Javelin 100 results, consider avelumab for appropriate patients, given the discussion that we had about the likely survival benefit that is given by this approach. I also consider a variety of first-line trials in my patients, but take into account the recent concurrent chemoimmunotherapy data presented at ESMO. There's, at present time, a reassessment and a need to consider carefully the pros and cons of each trial and see if that trial makes sense, if it's still asking a relevant question for patients. But different drugs, different immunotherapy agents may have different results, so it still remains a very important question if there is a role for concurrent chemoimmunotherapy or not with other agents. And then my practice is to obtain comprehensive molecular profile while patients are still in first-line therapy, and that allows me to have the results of the molecular profiling still when they're still receiving first-line chemotherapy. And that way, when they progress, we are not in a hurry to obtain molecular profile at that time and then wait several weeks to make second-line decisions. That's why I'm in favor of obtaining molecular profile right when patients are still getting first-line therapy. In terms of the second-line space, there are several different agents that would be available. Typically, the role of immunotherapy is considered. The patient selection heavily depends on comorbidities and presence or absence of autoimmune disease or use of steroids and issues related to the safety of immunotherapy. The question becomes, from a pathway perspective, what to do for patients who also have an FGFR mutation or fusion, as an example. Would there be a role for considering an FGFR inhibitor before or after immunotherapy in the second-line setting in those patients? And as I said, the data is evolving into, do those really represent different biological processes where a patient who has a tumor that has an FGFR mutation or fusion may not be responsive to immunotherapy? So this is too early to know the answer to these questions, but there's a lot of work ongoing to better refine molecular pathways and understand what is the best second-line approach for those patients. But at this time, we don't have a clear way to know if immunotherapy is going to work or not, and if FGFR inhibition should be used in the second or third line space for a patient like this. And similarly, the role of informal vedotin, the current approval is for patients who had prior chemotherapy and immunotherapy. But again, if a patient, for instance, had contraindications to immunotherapy, there is no reason to believe that the patient would not respond to informal vedotin in the second-line setting as well. So again, to me, it becomes a matter of understanding comorbidities and logistics and what is the best for that patient from a comorbidity standpoint. And there's a lot of clinical trials ongoing, and given all the agents that are approved, my preference is to offer trials that build upon the existing agents rather than trying a single agent, totally novel agent in that space. But on the other hand, in the third line setting, that's where I'm more inclined to consider novel agents in combination or in isolation. Given all the agents that we have, it's not uncommon that a patient, for instance, with an FGFR mutational fusion might receive first-line chemotherapy, might receive second-line immunotherapy, and then receives erdafitinib in the third-line setting as an example, and enfortumab vedotin in the fourth-line setting. So you have to basically decide what the patient had before and make decisions about what's best to use next. But we don't really have a perfect way to know what's the best sequence for each patient. And then lastly, there's cytotoxic chemotherapy that can be used. And typically this is used less and less in my experience because there's so many other agents available now. In terms of COVID-19 considerations, I think the same considerations apply here to any cancers. There's the ongoing databases and registries show there's no major significant increase in toxicity from any of the treatments that we have discussed about for metastatic urothelial carcinoma as relates to COVID-19 specifically. So there's the usual precautions for avoiding neutropenia, avoiding hospital admissions, but no particular considerations as relates to COVID-19 specifically in this patient population with these treatments that we discussed. So in conclusion, there's been a significant increase in the available treatments and in the therapeutic spaces for metastatic urothelial carcinoma in the last few years. There's been a likely increased overall survival over the last several years in this patient population, but it's very difficult to determine exactly what is the magnitude of this overall survival because all these different drugs that are now available don't have long-term overall survival data, and many of the studies do not incorporate subsequent treatments in the sequence because they're also new. So we still don't have at this point a good grasp on how much longer patients are surviving with metastatic disease, and that will become evident with registries over time. But we know that this is still a deadly disease for the vast majority of patients that eventually progress and pass away from the disease. And there's definitely a huge need to improve on the efficacy of all these treatments. We also know that currently, based on ESMO results, the chemoimmunotherapy approach concurrently is not established. And the only trial that showed the survival benefit was a phase 3 trial with switch maintenance of belimumab. And like I said, treatment selection based on molecular features other than FGFR alterations is still very difficult. And PD-L1 has not worked well as a biomarker in selecting who should or should not receive immunotherapy. But there should be an increased awareness of providers in obtaining early comprehensive molecular profiling so that options such as FGFR inhibition are not missed, and options for clinical trials targeting novel targets are not missed down the road for those patients. And the sequence of treatments really depends a lot on exclusionary comorbidities at this point. So I think it's very challenging to create pathways based on molecular features or based on any other features other than comorbidities because we just don't have that data at this point to guide our therapeutic decisions. But hopefully we'll have that data in the next several years as other studies mature with correlative data. And then lastly, the main hope that we have is that we're really going to bring all these new treatments forward to the earlier space and use them in a new adjuvant setting or use them along with local therapy. And that's where we have the potential of seeing the major impact. It really is in increasing the cure rates of patients who present either with non-metastatic, non-muscle invasive bladder cancer or with muscle invasive bladder cancer. And by doing so, we can hopefully increase the cure rates and truly reduce the chances of recurrence of these patients. And that's going to be the main way that we can make a huge impact on having patients survive this disease and have longer overall survival. I wanted to once again thank the organizers for inviting me for this talk, and I'm happy to take any questions.
Hi, we're here with Dr. Daniel Vina to answer some questions from the audience about his presentation. Daniel, first audience question is, for patients with hyperphosphate who are on erdafitinib, what's the cutoff before calling in a specialist, such as a nephrologist?
That's actually a great question. It really depends on your comfort level and the provider comfort level in managing hyperphosphatemia. You know, I confess I had to go back and go back to my internal medicine residency skills and look up hyperphosphatemia management to be able to deal with this. I would certainly say definitely for severe hyperphosphatemia, nephrologists should be consulted or could be consulted. There's very good guidance in the package inserts. I think the first step would be to carefully look at the package insert, and there's dose modification tables and what to do. But the additional factor is that it's very important to avoid calcium containing phosphate binders in this population, and so you have to be familiar with binders that are not calcium based, phosphate binders that are not calcium based, such as sevelamer. So there's a learning process for that. But I think once a provider is comfortable with that and follows the table on the package insert, then it's easier for the providers to manage this, because the phosphorus has to be checked so many times. It may just not be practical to call the nephrologist every 3 days. It's just impractical. So I prefer to manage it myself for the most part. But I had to refresh my mind on management of hyperphosphatemia and look into all these internal medicine type of questions.
So basically, like with many things, follow the directions. The second question is, with enfortumab vedotin, are you treating the neuropathy as you would for taxanes?
Yeah, so I haven't had that many patients developing severe neuropathy on it. You tried basically to screen patients ahead of time and not go down the route of enfortumab vedotin necessarily if they have severe neuropathy. But if the neuropathy worsens, again, the package insert has guidelines on when to dose reduce. I would certainly be in favor of managing with a variety of different neuropathy agents, like was mentioned about taxanes. I think that's fine, and it's sort of whatever works and follow those guidelines. But one of the important things is the dose reduction table that's in the package insert as well.
Great. Another audience question that's come in: immunotherapy adverse events versus traditional chemotherapy adverse events. Do you notice that patients have a preference for one versus the other?
Yeah, I mean, a lot of patients in general, across all tumor types, often look forward to immunotherapy in the sense that you don't get the traditional, cytotoxic chemotherapy side effects, so the nausea and the fatigue and all that. So that's definitely the same pattern across the board for all cancers. But it's very important to not lose sight that chemotherapy in urothelial carcinoma has a very important role, and especially in the first line setting. And so it would be, you really have to sometimes focus on not missing out on that option just because immunotherapy could be more, better tolerated or more convenient. Definitely chemotherapy definitely has a place in management of the disease and should not be overlooked. Great.
We have time for one more quick question here. For patients who have FGFR alterations, how do you currently determine the best second-line therapy for patients who have not had prior immunotherapy?
Yeah, that's an evolving question. I think it's a fascinating question because a lot of this depends on the molecular pathways and all that data is evolving. It's a complicated discussion. I think for the most part, you follow the data where the second line is typically with immunotherapy. But that being said, if you have a patient who's PD-L1 negative, for instance, the expectation of response rate might be on the lower side with immunotherapy. So if it's a patient where a response rate is highly needed because of some lesion that needs to be shrunk, and then the patient has FGFR alterations, the FGFR inhibitors might have a greater response rate. But other than that, I think following the typical pathway of immunotherapy, second and FGFR third is reasonable. But again, the next few years are going to clarify if those exploratory numbers that I showed, where it may be that patients are exclusionary, that patients who respond to FGFR inhibition don't respond to immunotherapy. We don't know that yet; it needs to be validated prospectively, but we'll learn about that next few years.
Great. Thank you, Dr. Vina, for your answers to these questions.